like speaking up for yourselves, that sort of thing. Yeah, because I promise you we don't, because I didn't, and so I just want you guys to know, like, just to kind of learn from that and help make sure you guys are getting a good experience in a controlled environment, right? Because that's the best way to learn. So I know I'm not a paramedic. I have never been an EMS. I've just been a nurse. And so I just want you guys to know that I am here as a OB speaker because, you know, I've done this for a really long time. Every single one of these emergency situations that is in your lecture, in your chapter, I have seen them and been a part of them. So you do it something long enough, right? You're gonna see those really rare situations. So I'm not here to, you know, to pretend that I know what it's like to be out in the field and whatnot. Have I delivered in parking lots and, you know, run outside to do these types of things in people's cars and whatnot? I absolutely have. So that definitely happens. But I try to tailor my PowerPoint to make sure it's, you know, according to how you guys are gonna be, you know, out in the field, and try to have it be in your guys' shoes. If anybody has any experiences, they want to chime in, you think your peers are gonna learn from it, you want to improve what I have to say, my feelings do not get hurt, you wanna raise your hand, you wanna correct me, you want to, you know, just to share in your experience, that is great, because I know this is not something that you're gonna see a ton, so the more you can learn now will be great for the future, and maybe a cool story will help you guys to remember that in the future when you do come across something. So I hear a lot of you guys chit-chatting when I first got here. You guys have been in some clinicals and whatnot in L&D, so that's cool. Sometimes when I come in, you guys have done none of that yet, and so this is all super fresh, and some of you guys have been involved, and so some of this will help click and when you have done some of this in the clinical field. So okay, I love it. Any questions before I get started? Anything you want to bring up? Okay. Any experiences so far that have been like out of the norm in your clinical experiences? Just kind of curious. Nothing, just regular vaginal deliveries, C-sections, all have gone well. Yeah. Say again.
I had one of those planes.
Cool. Yeah, that's really fun to watch. Yeah. Was it C-section?
C-section monodia.
Oh, okay. Okay. Yeah. So, yeah, twins are kind of fun to watch. So,
Monodia is
yeah.
Obviously the delivery, but I remember when I was on shift, there was a at-home birth that she kept hemorrhaging when we walked in. I remember I looked down and there was a placenta in a bucket, and I was like, all right, there it is. That was my first walk in. That was really tricky to see.
Placentas are really gnarly to look at for sure. Yes, those are
The metal bucket.
Yeah.
By the door.
Yeah, placentas, we'll talk more about that. Hopefully that just stays in, you know, and until you get to the hospital. Because that actually can help with hemorrhaging and that sort of thing. If that thing is inside, that can actually help. So we'll talk more about that. But, and then, what was the last thing I wanted to mention? I can't remember now. I'm sure I will remember it. Okay, so things we're gonna review and go over. So I know you guys have had anatomy and physiology, so we'll just review some of these things best we can. I won't get into too much detail. And then progression of pregnancy by systems, how it all affects the body and all of our organs. Of course, complications. There's a lot of OB emergencies, and they are rare, but they happen, and it's something you need to know about and know what to do. And then, of course, normal childbirth. 95% of the time, things go normal, right? So we'll definitely get into that so you know what to expect. There's a lot of scary things to talk about and learn, but for the most part, things go just fine. And then complications. So reproductive system. We have the uterus. This is the fundus that I was talking about when you guys do fundal massage. It's just the top of the uterus, and I apologize if I'm blocking you. Fallopian tubes are off, those little tubes that are kind of going off to the side. Ectopic pregnancies. So those are going to happen pretty early on. An absolute call that you guys could be going on. Those happen in the first trimester, usually 4, 5, 10, 12-ish weeks or whatnot. That is where a pregnancy doesn't make its way past the tubes, right? It's supposed to be implanting in the uterus, and it stops here. It gets blood flow from the tubes, and it starts to grow, and can get pretty far along, and it's very vascular. There's a lot of blood flow to the reproductive organs, And this can become an emergency pretty darn fast. You can see a lot of bleeding from ectopic pregnancies. They can get pretty far along, mostly because as women we have periods, we experience pain every month. A lot of times these things get ignored. We don't know we're pregnant, and so they, it's like, how do they get this far along, right? How do they get to 10, 12 weeks, pregnancies in tubes and whatnot? But a lot of people, think that, this ovulation pain, that they are just having period pains that are, coming up or whatnot, and then all of a sudden the tube can burst, and that's where we can have an internal hemorrhaging, and it becomes a true emergency. Those women are rushed immediately to surgery to get that fixed and taken out. It's taken seriously and moved quickly with ectopics. The ovaries, which this is not the best picture. So the ovaries are going to be over here. It's about the size of an almond, and so there can be cysts that grow on tubes and just fluid filled, not benign, but that can also cause pain, right? So you could be on a lot of pain calls, right? Severe pain. It could be a number of things, does she have an ectopic? Does she just have a cyst that maybe burst or is growing and has gotten really large on her tube? Did that cyst that's on her tube gotten so heavy and large that it has now caused an ovarian torsion? And so where that tube here then becomes heavy and twists on itself, right? So you guys have heard of torsions. Just like, how men can have testicular torsion, it's also something that can happen with our own tubes. So that can also cause severe pain that can come and go. It's positional. It can happen just, pain can happen just with sex. So these are all just, pelvic pain, just things to keep in mind whenever you guys go to calls. And then we have the cervix, which is the opening to the uterus. It's the opening to the reproductive organs. This should be nice and closed and thick. You guys will hear us talk about, vaginal exams at the hospital, like, it's closed, thick, and high, or we're trying to thin that out, we're trying to open it up, we're trying to use Pitocin or oxytocin to get that to open, right? And so the cervix is just the opening to the uterus. And then the vagina. So the main thing I want you guys to focus on when you are talking about and going on calls with the vagina. So there is a little cyst or a little gland that's in the Bartholin gland, and that is the gland that hangs out in the vagina that lubricates the vagina. So there are cysts that can form in that, and so that's something that can be more vaginal pain if that is something that you come across. And that can be caused from STIs, and so that's something that can be a cause for pain and concern. If it becomes infected, then we can, it can go all the way into, the infection can creep up into, through the cervix, into the uterus, into the rest of the body. So we can get sepsis from these cysts, STIs, which is also like pelvic inflammatory disease. Is when we have infections that go untreated and it goes to the rest of the body. Menstrual cycle. So there are different phases to the menstrual cycle. The ovarian cycle. So this is where we have the actual menstruation. It'll last a couple of weeks. This is where you have the buildup of the tissue, and then we ovulate, and hormone levels peak. We have release of the egg, and if it implants in those few weeks that the body is ready for implantation, then women become pregnant, right? If not, then the body then releases all the tissue that has been built up, and that's where the release of the tissue and bleeding occurs. Just a fun little cartoon about where everything joins in the uterus. So pregnancy is when we have the sperm and the egg obviously combine, make their way through the fallopian tubes, get all the way to the uterus, and it will implant after several weeks. And so, this is a really popular time for miscarriage if that implantation doesn't, connect and doesn't occur, right? So that's why early, 4, 5, 6, 7 week, miscarriages happen, because this whole process needs to, take place. So, we have all this vasculature that needs to connect, to the myometrium, to the inside of the uterus. And so, that is a very, delicate balance, within the body. And then the fetus, the baby now gets to be called a fetus after, those 8 weeks as an embryo successfully implants to the mom. We have now, after those first couple of months, we have a fetus that, continues to grow through those 9 months. Placenta, so developing on both sides of the body, right, from mom and baby. This is where exchange of gases, nutrients, blood flow, all by diffusion. And so you can see how, with an implantation, all the little, villi that connect from mom to baby, that diffusion and that exchange happens. There are membranes that connect, all around baby. It encases the baby. It has 2 different, layers to it. It's the amnion and the chorion. And so, I don't know if you're at the hospital and you hear us talk about chorio, that is where there's like an infection that's going on the inside of the body. And so that comes from, that word, the chorio. So chorioamnionitis, right? So the chorion and the amnion have become infected. So you might hear us nickname it, as chorio. That is where a fever and infection, results after, being in labor too long, maybe premature rupture of membranes. And so, it's just a source of infection. And then the umbilical cord, 2 veins and 1 artery. So if you get to look at it in a placenta after delivery, if you want to look at the end of the cord, it's really, kind of interesting to see, how the, cord, its anatomy, and it's really fun to look at it. Fetal development, so heartbeat is at 4 weeks. By 8 weeks, organs are formed. You can see the measurement of baby is not even an inch yet. And so by 12 weeks, baby is 2 to 3 inches. So remember we were talking about ectopic pregnancies, and they are up to around 12 weeks. Because at that point, the fallopian tube stretches right to 2 to 3 inches, and that's why it doesn't usually get past 12 weeks. Because fallopian tubes are usually only about a half an inch in diameter. So imagine, a 12-week fetus getting to 2 to 3 inches, and that's where that why that will resolve itself eventually. 8 to 12 weeks, baby's heart rate can be heard by ultrasound or Doppler. So office visits, or if you guys are on a crew that it uses a Doppler, just if you can remember, if you have a really early pregnant mom, you probably won't get to hear the heart rate. Sometimes we get called from the ER to go down and try to Doppler, and that is the first question I ask is how many weeks are they? Because it's pretty hard even in these many weeks to find the baby sometimes because they're just so little. We usually recommend an ultrasound. 16 weeks, baby sex can be seen. It's really thin looking. It's really red. The skin is just really thin. So if you ever see a miscarriage, or if there is an IUFD in the hospital at the time and you want to ask to see it, I know that sounds kind of morbid, but the more you see and the more you do at the hospital, it can really set you up for not being, too surprised if you do have to go to a call that someone is miscarrying, because those babies do look pretty crazy, pretty alien-like. Everyone, says that because they're just really, the skin is like see-through, and there's just no fat on the body, and so they kind of look a little alienish. Yes.
We had a call for a miscarriage where she felt like she passed like a clot, and I was the only female there, so I took a trauma pad, and when she stood up, the fetus was hanging outside of her by the umbilical cord, and she was probably like that big. It was just super tiny, and that was.
How many weeks was she? So was that
She
about?
wasn't sure. 'Cause she had just recently found out, so my guess was around 6 to 8, but it was just like hanging
Right.
outside of.
Yeah, pretty common. So that's an incomplete miscarriage or incomplete abortion. And so I know we tend to use the word abortion for when somebody electively goes and, and has a termination of a pregnancy. But abortion means two things. So you might see it in your text, in conversation, in the PowerPoint, the word abortion. And so there is, elective or therapeutic abortion, and then there's spontaneous abortion, and that's the same thing as a miscarriage. So incomplete abortions is where baby comes out and the placenta doesn't come. So really, really common. Those women are brought to us, and sometimes we have to go and manually and surgically scrape out the placenta and get the remaining tissue and whatnot. So it's unfortunate. It's a really high risk for infection. It's a really high risk for them hemorrhaging when that tissue doesn't want to come out. So yes, sir.
When I was at a desert last week, we had a premature birth that was 22 and a half weeks, I think.
Wow. Mm-hmm.
They said that, the NICU team said that it looked like there was a cranial hemorrhage because the head was like purple red, like it was just all the blood was up there, and then the waist down, the word he used was gelatinous, but it just looked clear, almost see-through.
Yeah.
Is that presentation for the bottom half of the body, is that because there's no blood circulating down there, or is that what it should have looked like had there been no hemorrhage, like in general?
So was the bones just like gelatinous too? Like the whole body was gelatinous, or because
the
legs were.
It was like yellow white tissue.
Oh, interesting.
Almost
So there is certain conditions like hydrops. I don't know if you guys have read or heard of hydrops, and that can cause, one of the side effects of hydrops is severe edema in the body. So there's just a lot of, so it makes everything feel very soft and gel-like and whatnot.
Okay.
So I wonder if that baby had hydrops, but not usually. I mean, a gelatinous body is not normal. That's not typical. As you know, so viability is 22 to 23 weeks, depending on what hospital you go to. And so that should be, or could be, a viable baby that we could take to the NICU and hopefully, get to term to discharge. And so that definitely isn't normal. So, yeah.
The NICU team said that the baby did have a heartbeat, but because of the cranial bleed and the presentation of the legs and the fluid challenge, that very low likelihood of surviving, and the family didn't want the baby to be worked. So.
Yeah, for sure, yeah.
So
really, really fragile vessels in really small babies. If you are a part of a call that you have a delivery under 32 weeks, and we'll get more into it when we do the neonate lecture, under 32 weeks, you do not do stimulation. So if that baby comes out, you're going to pat dry, immediately put in a plastic bag or whatever you have, and you're going to try to keep, how when you get into plastic, just starts warming yourself up. That's how you're going to keep your baby warm. You do not do any sort of stimulation, or besides maybe just a little bit of pat drying. So very, very fragile vessels, and that's under 32 weeks. So imagine at 22 weeks, that's a very fragile baby, very fragile vessels, especially in the brain. So yeah, that's unfortunate. Gosh, poor thing. Good. That's a good learning experience for sure. By 20 weeks, heartbeat can be heard on a fetoscope. That is a really old school tool. Midwives, some may use it for home births, but I feel like Dopplers are very much used widespread now, that those are used at home. People can buy them now themselves. So I should add the word with the fetoscope and a Doppler. By 20 weeks, fetal movements by around 20 weeks. It can be a little bit less, it might be a little bit more. I just put that as a general. 20 weeks, most women will feel fetal movement. And the reason why that's important to remember, so you are at a call with someone that is around that gestation. If you ask them if they feel fetal movement, that can be really reassuring. That's the number one way we know babies are doing well. It's a very important question when I'm triaging pregnant women at work. When they come in, that's immediately what I want to know, because I know that baby is most likely doing okay. There's at least circulation to baby, and baby is alive, right? So that's something that you can take note of around that many weeks. It can reassure your patient too, right? Because it's really about trying to keep your patient calm, and the big thing is she's worrying about her baby, right? So fetal movement can be a good sign. Hand skin grasp, so we have muscle development is getting better and better halfway through. Vernix, you guys know what Vernix is? That white, cheesy, cottage cheesy kind of looking thick like creamy lotion that is all around and all over babies' bodies. And that is Mother Nature's great way of protecting babies. They have a really, really thin skin, and so Vernix can be great for protecting that. And the earlier you see babies being born at the hospital, like the 22-weeker might have had a really good coating of Vernix. They have more, if you see a 36-week delivery, 35-week delivery, you might see a lot of Vernix. And so that is something that slowly dissolves away the farther along someone is pregnant. And so if you see like a 40, 41, 42-week delivery, you might see a baby that has peeling skin. They look really wrinkly because all of the Vernix usually dissipates by like 39, 40 weeks. And so it's just the difference. It can be an indicator to help you figure out sometimes how far along this mom is if she has no idea. So you baby that has lots of Vernix, you're guessing it's probably a little premature versus babies that have none. So, because it's not necessarily all about size, right? Some babies have failure to thrive, and so you can't always guess how far along moms are just for how big these babies are. And then 24 weeks, that is dropped to, depending on your hospital that you go to, 22, 23 weeks for viability, and that's really something that is the comfort of the staff, what parents want to do, right? So nationally, 24 weeks is kind of the viability. It has a pretty high percentage of survivability of these babies, so it's kind of 50-50 at 24 weeks. And so that is usually at 24 weeks, we are doing everything that we can, right? We're not just doing like palliative care and trying to just do comfort measures. Like with the 22-weeker, that's probably, where they might have gone with that. It's just kind of, letting the parents enjoy that baby for as long as it possibly was alive for, right? If it was 5 minutes or 5 hours. So, but 24 weeks, we're gonna do all we can to see if that baby can make it or not. We let that baby determine that. Weighs about 1.5 pounds, 1 pound 10 ounces on average. And there are some respiratory movements that have developed at that point. And that's the big thing, right, with viability is baby doesn't have that respiratory drive and the ability to breathe on its own. It doesn't have that buildup of surfactant. That is something that the body makes in the lungs that allows the air sacs to be able to open and exchange air and gases. That usually doesn't happen until this many weeks. 28 weeks, these are our big numbers at when we're taking care of moms too. As you can see, they kind of jump every month. So we have 20, 24, you can kind of see the pattern here, 28. We have big jumps every month with different developmental stages with these babies. So 28 weeks, even better. So I should put the percentages up there. 28 weeks, it gets into like the 80-90% of viability and survivability without any detrimental long-term effects. So it's great if moms that have high-risk pregnancies can get this far along. So we have babies now have that surfactant that is formed. If it's so that's what makes viability the big determinant here. Because if there isn't their surfactants, you can vent babies, you can breathe for them all you want, but if their lungs collapse and they're not able to, take in that oxygen and do that gas exchange, there's nothing you can do for those kiddos. So that's what's happened at 28 weeks, and they are 2/3 what their size is going to be. 32 weeks, fingernails, toenails, fats collecting. They look like just little mini babies, honestly. They're looking less red, less see-through, and they're starting to fill out a little bit. Viability becomes more and more in the 90%. And then term at 37 weeks, that is specifically term. So I know sometimes moms will come in and be like, yeah, I delivered a little bit early, and they'll tell me they delivered at 38 weeks or 37 weeks, and I'm like, oh, that, you know, your term, that was just fine. So those last few weeks, honestly, those babies are just getting bigger and getting fatter. So 37 weeks is term. The longer they stay in, the better. Sometimes babies, you know, that are born even a few weeks early, sometimes struggle with respiratory drive and whatnot. So the longer they stay in, obviously, we do not induce moms less than 39 weeks. It's a national standard across the whole country. So even though moms are term at 37 weeks, that is something we want them to stay in, get fatter, get, you know, immunities built up. So it's important, even though they're term, we want them to stay pregnant as long as possible. So just trimesters, you guys know that pregnancies are kind of defined by their trimesters. There's 3 of them, and so this is just kind of a quick little reminder of your trimesters. Just break those 40 weeks down, right, into thirds. So, getting more into just the physiological part of pregnancy, and then symptoms of pregnancy and that sort of thing. So the uterus, lots of hormones going on when you're pregnant. We have high levels of estrogen and progesterone to support a pregnancy. And so the body has to make that in order to have a pregnancy survive, honestly. If you've ever had a baby, your wife, sister, mom, or whatnot has ever talked about their pregnancy, sometimes they're put on progesterone medications to help keep themselves pregnant. So that's really important that these hormones are in high levels because they do a lot of important things for the pregnancy. And so if you ever go on a call of moms being at home on bed rest and then you're going over medications with them and what they're on, you might hear that, like progesterone supplements, and a lot of times they are taking it rectally, actually. So these high levels of hormones, they're helping to thicken the uterine wall. We want a nice, thick, strong uterine wall. It helps keep the vagina and the connective tissue soft, and that's going to help accommodate, you know, just that slight adjusting and opening of everything in the joints for delivery later on. Cervical glands do produce a mucus plug, so that's fun to see when, you know, if you've seen that at the hospital or you're out in the delivery. The mucus plug is there on purpose to help protect anything going up into the uterus. So again, the body's trying to prevent, you know, that the chorioamnionitis, trying to prevent, you know, moms get STIs during pregnancy. Hopefully that's going to help block from that infection creeping up into the uterus, preventing PID, and then also the different levels of these hormones can also stimulate Braxton Hicks contractions. So you guys we'll talk more about that a little bit later. But Braxton Hicks, those are those contractions that shouldn't be uncomfortable. The stomach, the uterus just kind of hardens and then relaxes, and those are just those practice contractions the body is doing. This picture is awesome. I really like this because I want you guys to focus on if you are at a call and you have someone that doesn't know how far along they are, this can be a good guesstimate if you lay hands on the stomach and you can feel the top of the fundus. So if you are, you know, kind of feeling for, you know, the roundness and whatnot, and you feel that it's happening right at the belly button, then that is how many weeks?
20.
About 20, yes. And so that is kind of a guesstimate that, you know, she is around 20, 22 weeks. And so it can be a really nice indicator to see how far along she is. Full term is going to be all the way up to the xiphoid process, kind of depending on, you know, the size of the baby, and everybody's anatomy is a little bit different, but this can be a really nice indicator on as to see if you can, you know, get a guesstimate. Someone doesn't know their last menstrual period, they haven't gotten prenatal care, you know, it can be hard. So this is kind of a nice hands-on way to help figure out how far along someone is. Uteruses, they grow to a massive size, right? So they're normally about the size of a fist. They're really low down behind the pubic bone, and they grow 20 times its size to accommodate a full-term pregnancy. There's lots of blood flow to the uterus. I bolded it and underlined it, and just to make it really, really stand out, that blood flow to the uterus is massive. At term, it is 500 to 600 mLs a minute of that blood flow going through the uterus and to the baby into the placenta. At one time, the amount of blood flow that is, in, placenta, uterus, all of the uterine arteries can be up to a liter. So you can see how if there is massive trauma, someone's hemorrhaging and whatnot, how fast somebody can hemorrhage and bleed out. Pregnancies do accommodate blood loss well. Women make an extra liter or two of blood to accommodate a pregnancy, which then helps compensate for after delivery. You guys have seen deliveries, and a lot of times we try to guesstimate what is their blood loss. We can track it throughout their recovery, and 300, 400, 500, 600 cc blood loss is very, very normal, and that mom will do just fine because she had an extra liter on board anyways, right? So it's pretty normal. It looks like a lot of blood, but they should recover just fine from it. And if we have any concerns, if they came in, anemic or already on the low side, sometimes we'll do blood work to make sure that they're doing okay before they get discharged home, since we have to give them a unit of blood, but they usually do just fine. Yes.
Sorry, can you repeat that? You said, so when is it okay to see like 500 to 600?
Just in any delivery.
Any?
Yeah, vaginal,
During
C-section.
delivery.
Pardon me?
During delivery, my bad, I was writing what you were saying.
During delivery, yeah. So after delivery, a lot of times we will look like what's in the plastic bag that's underneath mom. We will look at all the laps that have blood on them, and we weigh them. And so we try to get an estimate to see what the blood loss is, because we like to track it. And so I just want you guys to know that if you see a puddle of blood, that you know that it's nothing that usually of concern, because 300, 400, 500, 600 is absolutely normal. We don't get concerned until it gets to be a liter. We don't label it as a postpartum hemorrhage until after 1,000 cc's actually. So several hundred of a blood losses can be absolutely normal. So does that answer your question?
Yes.
Yeah. Okay. And then first trimester, 200 to 300 mLs per minute is the blood flow through the uterus. Second trimester increases even more. So that is just to really illustrate and have you guys hit home for going on those miscarriage or abortion calls. Someone is miscarrying, and you can see a lot of blood. It can be pretty scary. But again, if you think about it, if they started bleeding and they're miscarrying, and you don't get there for 5 minutes, you can see how that there could be a liter of blood hanging out on her bed or on her towels or whatnot, and that's because that's how much blood flow is going to the uterus. So it's a lot, and so spending minimal amount of time on the scene is really important. I would say getting IV access and getting two is awesome. That way we need to transfuse her. We got a line before she starts to decompensate possibly or whatnot, and we lose IV sites. I will mention that multiple times in this lecture. Getting 2 IV sites, please. That would be awesome. We would love you guys for it. Yes.
What age preferable?
We use 18 on every patient, and so unless we have to use a 20, but yeah, just you guys can put 2 18s in. That'd be great. So 20s are fine too. But yeah, it's our every admit. We automatically do an 18. We always treat everyone as if they could potentially be a hemorrhage, and because you never know, and so everyone gets an 18. Yeah. Yes.
So like our kind of standard is AC or higher. One of the nurses told me that they prefer forearms because when the mother's bearing down, a lot of times that'll get occluded better, so it takes the side a little lower. Is that something at Chandler as well?
Absolutely, yeah. So any laboring mom, I would encourage you guys to do forearm if you guys can. We lose a lot of sites when it comes to like moms, especially if they don't have an epidural. You bring them in very active. We can't get them an epidural. I mean, they're moving. They're trying to just get through all this pain, and then sometimes you pull an IV out and you can see they're just kinked off because it's in this site. ACs are not our favorite. I mean, I will take what I can get. I'm not picky. I know you guys are dealing with a lot, you're trying to place it, you know, in the ambo, I mean, there's a lot going on, so you do what you need to do. But if, you know, there are some really healthy, you know, moms that have great IV sites, and so sometimes I'm kind of like bummed out, cause I'm like, you know, there's beautiful veins here when, you know, you just, you know, and I get it, it's habit, you're trying to move fast, do what you gotta do, but forearm would be amazing, yes, I would appreciate that, thank you for bringing that up, yes. And then, I mean, there's a lot of women that are swollen, there's a lot of edema going on in pregnancy, so it's hard, it can be a really hard thing. Sometimes I mean, the other day I had to put one literally here, right at the knuckle, right, like right here, and I had to do a 22, it was pathetic, but that was all I could find and get, and she had been poked multiple times by other people, you gotta do what you gotta do, so. Okay, and then, more things with the uterus, so acid, and the pH of the vagina changes, so just to get more into, infectious stuff, just to kind of point out, BV, bacterial vaginosis, yeast infections, the gynecological health is, definitely, off, and there's definitely increased incidences of BV and yeast infections, so odor is different during pregnancy, and it's all normal, it's just what happens, because of the pregnancy and hormone changes, and so that's just something to kind of keep in mind. Cardiovascularly, so we have a decrease in peripheral vascular resistance in the first trimester, right? So that's gonna cause a decrease in blood pressure, so if moms are kind of hanging out low, you have an early, like first trimester mom, you know, and then she's miscarrying on top of that with blood loss, so lower blood pressures can be pretty common. And as long as she's not symptomatic and she seems fairly stable, that can be okay. And then we have increase in blood volume, like I had mentioned in the previous slide, 40 to 50%, a liter and a half or so increase. And then heart rate will increase to kind of compensate for that increased blood volume. Cardiac output increases a good amount, and sometimes it can cause an increase in heart size and dilation of vessels. And so moms that already have cardiac issues, pregnancy is really, really hard on them, because you can imagine trying to compensate for all this extra blood volume and the demands of the placenta and the pregnancy. It can be really hard. Talked about increased blood volume, supine hypotensive syndrome. Let's just skip down to that. So really, really important. This is the why behind why we always place moms on, you know, left lateral when you're transporting them, or at least at a tilt if they don't want to lay on their left side. Just as long as they're not flat on their back, if you could place, you know, like a flattened or folded pillow underneath their side, really is to get them off of that vena cava that runs along the backside and the abdomen, right? So it's a major vessel that helps to do perfusion to the uterus and to the baby. And so you decrease blood flow to baby when moms are laying flat on their back. So we're gonna make sure they're minimal at a tilt. If they can be on their left side, if they hate their left side, put them on the right side. Left is like a little bit better than the right, but it's not like this huge significant difference. I feel like it's stressed a lot, and it's in a lot of books and whatnot, like left, 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 left. Use that for your test or whatever it uses, but right side is absolutely fine also. And then hypercoagulability, that is pregnant moms are in a very hypercoagulable state during pregnancy. The body does that and increases coagulation factors on purpose, right? We are trying to prevent hemorrhage, prevent blood loss at delivery, and so the body is doing that as a protective mechanism, right? However, it also increases a risk for emboli, for blood clots, 4 to 5 times, and that is through several weeks post-delivery. And so that is something that if you go to a call for somebody that, you know, is having a PE or, you know, a DVT or calf pain or whatnot, and they've recently had a baby, that is something that the body takes several weeks to kind of adjust and go back to a non-pregnant state. And so this is just something to keep in the back of your head for pregnant moms and their risk for PEs and even AFEs. And we'll talk more about AFE, which is an amniotic fluid embolism, and then pulmonary emboli. Increased venous pressure, so that is where we got lots of swollen moms. So we just have a lot of pressure built up in our the venous system. Therefore, hemorrhoids can happen, varicose veins, etc. Respiratory system. So hormones stimulate the respiratory center in the second trimester. So we have increase in tidal volume by 30-40%, slight increase in respiratory rate, increase in inspiratory capacity. So all of those things are going to compensate for extra blood volume. We have demands from the placenta and the baby to deliver oxygen and deliver gases to that baby. And so you have a lot of extra demands on the respiratory center. You can see oxygen consumption is up by 15 to 20%, which is why the respiratory rate increases to compensate for that. And so slight hyperventilation can be normal. You know, you see pregnant moms that, you know, they're just sitting there and they're, you know, just breathing extra. You know, all they did was walk from their cars and sit down, right? And so sometimes it's just, that is just the demands of all that extra blood volume and consumption by baby. Difficulty breathing can start to happen in the second trimester also, right? Because we have pressure building up against the diaphragm. So you can see in the picture below, especially in the third trimester, this gets pretty rough. Vascular engorgement, smooth muscle relaxation. Hormones in the body during pregnancy on purpose will slow down the smooth muscle throughout the body. And I'll talk more about that with the GI system, but it's all to just keep moms pregnant, right? We want to slow everything down, we want to keep everything calm, and so that's why we have like nasal and sinus congestion. There is constipation is really normal in the GI system because of it, so that's all normal. And then, like I said, the diaphragm is being displaced by the enlarging uterus, and so there's shifting from abdominal breathing to more of that thoracic, you know, breathing and just really using, you know, that lung power more higher. And then estrogen causing relaxation of the ligaments and joints. So the body needs to be able to expand more to compensate for oxygen consumption. So estrogen really relaxes the ligaments in the ribs, and so that will help that expansion. And when we get to muscular system, that also happens with estrogen and relaxin. That's another hormone that will relax the ligaments. It helps to expand the joints to be able to accommodate birthing later on. So you'll notice like women might waddle, it might be harder for them to get up and down because the body is just not as like secure, and those ligaments and tendons aren't quite as tight and secure for supporting of the skeletal system, right? And so that is why some women will have the pregnancy waddle. Renal system. So the ureters become elongated. Again, there's smooth muscle relaxing, so there's decreased motility, which leads to urinary stasis, right? So the urine is not flowing as well. It's kind of hanging out in the ureters and the bladder a little bit longer. And so I know it seems like pregnant women are going pee all the time, but they're not completely emptying it, right? Because everything has kind of been relaxed and slowed down a little bit. Increases their risk for UTIs, which can develop into pyelo. I have plenty of moms that come into the hospital with UTIs, and that they've maybe they didn't take all their antibiotics, they're not emptying their bladder all the way, they're not staying hydrated, and these women develop pyelo and sometimes get sepsis. And so it's pretty common to have somebody at Chandler in the hospital with us with pyelo on the medical floor or on our floor as an antepartum patient. So it's taken pretty seriously. We don't want them to develop sepsis. We don't want that to get to the baby and have that affect the pregnancy and cause preterm delivery. So They are hospitalized with us, and kept for at least a day or two for IV antibiotics. And then, of course, decreased bladder tone, like we've already talked about, just causes increase in the frequency of need to use the bathroom, and sometimes even incontinence. So it's not just that baby is hanging out on the bladder and pushing on it, so that can cause leaking. It can just be flat out, those extra hormones are just not allowing for the ability for everything to kind of stay nice and closed, and being able to be controlled by the body as well. And then pressure of the enlarging uterus just flat being on the renal structures. So that is going to cause, obstruction, maybe decreased motility of urine, and causing, not full emptying of the bladder also. GI system, so decreased muscle tone here also, right? So it has slowing of the digestive processes. This will lead to, nausea, that things are hanging out in there longer than normal. Nausea and vomiting can occur, morning sickness, right, constipation. And in the gallbladder, if there is, slowing of, what the gallbladder does for digestion, we have increased risk for gallstone formation and cholestasis. And then heartburn, right? So that's where everything kind of just gets backed up, things aren't moving, and that's where all of this is happening. So all these hormones are important to maintaining a pregnancy, but there's a lot of side effects and things that happen in the long term that pregnant women kind of suffer to maintain a pregnancy. So that's why all this happens. And then changes in senses of taste and smell. So we have that increased blood volume to our nose, to our taste buds. So sometimes that can enhance taste and smell. And so I know when I was pregnant, I don't know if any of you guys have had any kiddos, but things just smelled like just super, super highly attuned to smells. Everything just was horrid, and I could smell every tiny little thing. It was major. And then, to continue with more musculoskeletal system, distension of the abdomen, starting in the second and then of course in the third trimester. This is gonna cause that shifting of the center of gravity, right, more forward. There's a lot going on up front. And so this can cause lordosis, which is where the spine, scoliosis is where the shape of the back is more S-shaped, where lordosis is where like the pelvis, kind of goes backwards to accommodate the large belly. This can cause clumsiness, trips, falls. This can be a big deal for you guys because you could be going to, I'll call it the grocery store of a pregnant mom, tripped and fell at the grocery store and whatnot, and so it fell on her belly. That can cause, falls are really, 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 really big deal. And so I really go on a soapbox about falls with pregnant women because, and we'll talk more about placental abruption, but even a fall can cause that placenta to kind of get jarred and can cause like a little small abruption in pregnant women. So take those very seriously. Even if mom thinks she doesn't need to go to the hospital, I would definitely encourage that so we can lay eyes on the inside of her belly and get an ultrasound and check out the placenta. Just like a quick story, a couple months ago I was triaging a girl that came in the next day from being in a low-speed car accident. She got sent from the office that day straight to me because the doc was like, you were in a car accident yesterday and you didn't go to the hospital. So she was like, go straight to the hospital. We're gonna do lab work and ultrasound. So I'm talking to her and I was like, did you not think to come in? Or, it's really important to come in anytime that there is, I know this doesn't seem like a big deal because it was a low-speed accident, but you always want to make sure, we're not just concerned about the baby, we're concerned about your placenta, right? That's the lifeline to your baby. She was like, yeah, the fire department came and they asked me if I wanted to, but I said I felt fine, so they said I didn't have to, only if I wanted to. And so I only share that story because I know you guys have the ability, because my husband is a firefighter paramedic, and and he always tells me stories about like he was like, you know, trying to really convince someone to go or not go, and I know you guys can't make people go, but I would never let a pregnant woman make that decision necessarily on her own. I know you guys have good, you know, persuasive skills of being like, hey, I think you should go for the, you know, the sake of the baby. Make it all about the baby, right? Want to make sure your baby is doing well. Want to make sure that placenta is doing well. Because I honestly was kind of surprised that they were like, okay, you know, go ahead and go home. And everything was fine. The baby was fine and whatnot. But I have had women just come in and fall, like stepping off the curb and then falling, and she just, you know, went down on her butt and just that, and she had gotten a small placental abruption. We kept her for about a week to watch to make sure, because she was having vaginal bleeding. It was enough and big enough that we wanted to keep an eye on it, make sure it's that placenta healed itself over, you know, kind of, you know, the coagulation factors kind of, you know, clotted that back off, and she was able to go back home on bed rest and come back, you know, she had further vaginal bleeding. But that is the, you know, kind of the life lesson behind just making sure that, you know, just always err on the side of caution and send those moms in pretty quickly. So, makes sense? What do you mean? Okay. And then diastasis recti, you know how the muscles in the stomach, they run up and down. So pregnancies just cause those muscles to kind of separate. It can be pretty uncomfortable, pretty painful, and so that's what diastasis recti is just the separation of those abdominal muscles. If you see a C-section, you will watch them physically do that with the muscles. They hold on and they pull from each side and pull those muscles open to get to the uterus. So if she didn't already have diastasis recti, she now has it from her C-section. So I know a lot of women are like, C-sections are great, and you know sometimes it's electively done, but it's pretty gnarly with what happens to the body.
Does that go away, or is that like a permanent?
So some doctors will
to correct
stitch those muscles back together again, most do not. And so, yeah, they just let those muscles come back together. If you work out and build those muscles back up, it can really help, but they don't, I mean, hopefully they do. Hopefully the body can heal itself, yeah.
So I saw it two different ways. One of the docs was like very gentle with the uterus and like sliced through very like almost layer by layer. And another one got a little hole and then stuck some fingers in there, widened it up. Is that pretty common with the uterus as well? Okay.
Yeah. It's just different techniques.
Shocking.
Yeah, it's pretty shocking, yeah.
Yeah.
Some people just like stuck their finger in and just
Yeah.
rip it open and
I was expecting it with the muscle, but you know, uterus.
So, when you
Yeah,
guys
but-
see that, whenever there is tearing, like even pulling the muscles open, and then just pulling the uterus open too, the rationale behind it is, you know, like when you have a piece of paper, like, you know, there's no tear in it, it's not gonna tear. So if there's already a tear in it, like how easy it for that to continue to tear. So they're trying to prevent, you know, just continue tearing if they were to just like cut it and then try to pull the baby through. If sometimes these big babies that are trying to pull through, if it can cause further extension of the cut, can cause it to be. It's the same philosophy with, let me just say, with like episiotomies. That is very much not done anymore. That is like pretty uncommon. You won't see episiotomies during vaginal deliveries because the thought is if you make that little snip as that baby's coming out, the tearing is so much more able to happen when you already have that start to the cut, to the tear, to the tissue. So episiotomies are usually only used absolutely if necessary. So because those tears going down and deep is high risk for moms. So same thing with the uterus. They're just trying to like create a hole that doesn't extend as they yank baby out. So yeah. And then integumentary system hormones from the thyroid is going to cause hot flashes, facial flushing, and then hyperpigmentation. This does not happen with all women. But melasma, which is what the picture is showing. It's just like that. It's also called like the brown, you know, like the pregnancy mask or mask of pregnancy. It's just brown facial pigmentation that settles on the face. And I don't know if you guys ever see like linea negra. It's just a medical term for the with the belly, from like the pubic to the belly button, causes like a little brown line. It's just extra pigmentation in those areas. So just all pregnancy related. And then stretch marks are really common in pregnancy too. And then endocrine system. So hormone changes obviously are going to cause amenorrhea, which is no period. I know that women that don't realize that they're pregnant, or they go months and months, and they don't find out they're pregnant until several months along. They're like, I got a period every month, I swear. That is to me a little suspicious. I feel like, maybe if they had, implantation at the beginning for the first month or two, sometimes there's like a little bit of bleeding that happens here and there. If there was like a little, there's what's called like subchorionic hemorrhages, where like as the implantation in the placenta is settling, sometimes there'll be like a little bleed at the edge of the placenta, which can happen anytime throughout the whole pregnancy. Some people can have some, bleeding from that, or if sex caused, some vaginal bleeding. Women do not get their periods during their pregnancy, so that is something that is not happening. And then increased progesterone throughout the entire pregnancy. That is a big one. Think about pregnant progesterone, the 2 P's, right? So progesterone is very important to a pregnancy, like we said, and being on progesterone can be very common for women that are trying to sustain a pregnancy, or if they have a history of preterm labor. Women that contract a lot during their pregnancy or threaten preterm delivery, they might be on progesterone. And then increased prolactin, that's at the very end. The body increases that hormone to facilitate lactation and milk production. So you can think of like lactating, prolactin, that's the help with producing milk. And then the body does naturally make oxytocin in the last trimester. Those values go up. Also, it starts to get the body to start doing Braxton Hicks also, so stimulating the uterine contractions, right? So it starts out really low, practice contractions, all the way to when it's labor time. And then oxytocin also goes to the breast for milk letdown, and that is really important for right after delivery too. Increased BMR, so the metabolic rate increases. Again, so you have the demands of the fetus and metabolic activity that we need to deliver to babies. So we have moms that can chronically have hypoglycemia throughout their pregnancy because it's just a lot of demand on the body. So snacking frequently is really important. Moms can be, they can be a patient of yours if they faint, right? And you go to them to do a blood sugar and it's really low. That absolutely happens. Sometimes we have moms come in that we have to, we diagnose them with diabetes and we're aware that they became diabetic. The body can go into a state of resistance to insulin, and so their levels can be, high, low, they're kind of all over the place. And so we have to help regulate them for a couple of days, do some education, and then they get discharged home to continue that on their own. But increased cortisol will cause maternal resistance to your own insulin. And so they might have to start giving themselves insulin or taking medications like metformin. And so that's might be on the med list of a pregnant patient that you might have is metformin, or both metformin and insulin. Increased need for glucose due to developing fetus. Oh yeah, talked about that. Do you guys want to take a little break since it's been about an hour? Okay.
Yes.